And welcome, David.
Thank you very much. Good evening, everyone. And thank you all for coming on this cold night. It's nice to be here. So I'm a psychiatrist, and I'm the director of the Depression Clinical and Research Program at the Massachusetts General Hospital, and I'm a professor of psychiatry at Harvard Medical School. And the title of tonight's talk is Seasonal Affective Disorder, or How to Beat the Winter Blues. I'm just listing here some of my disclosures. My research has been funded by various different organizations, and I've also written textbooks and received royalties for them, as well as honoraria for speaking and writing from different organizations. So in this lecture, I'm going to cover first a little bit about seasonal depression. What is it? Who might get it? How do we diagnose it? And then the practical portions. What what are the different approaches to treatment? And how might we use light therapy in particular, which is the leading treatment for this condition? So let me start by talking a little bit about depression in general. What is it? So the technical term for depression is major depressive disorder. And it has a prevalence across the world of somewhere between 10 and 20%. So 10 to 20% of people might expect to get depression. Depression seems to be more common in women than in men. The ratio is about 2 to 1. We don't really know why, though. Many different theories have been offered. Getting more into the role of the environment in promoting depression, it is known that prevalence tends to increase with latitude in North America. So the farther north you go, the more depression you will find. But these patterns are less clear elsewhere. Just to make a comparison, in New Hampshire, about 9.7% of people may have depression, as compared to Florida, where it's 1.4%. So it's almost a tenfold difference. Now, what about seasonal depression? So seasonal depression is actually a subtype of major depression. And it's estimated that of all people who may have depression, about 10 to 20% of those individuals will have a seasonal pattern to their depression. This particular subtype, referred to as seasonal affective disorder, is also called the winter blues, kind of in the vernacular speech. Bipolar disorder, which is related to depression in that it has both a depressed phase and a manic or excited phase. Bipolar illness may also have a seasonal pattern, with symptoms presenting more during the winter months. Typically with seasonal depression, the mood episodes will occur and remit at a given time of the year. Typically, people will get depressed during the fall and winter months, and then they'll usually get well in the spring or summer, and in cases of bipolar disorder, they may actually become manic during the spring or summer. In some people, however, the opposite pattern is also seen. They may become depressed more during the summer than during the winter, but this is less common. From the standpoint of diagnosing the condition, an individual is required to have had at least 2 consecutive episodes in line with the fall, typically, in order for the diagnosis to be made. So they have to have had it happen at least twice consecutively, that is, on consecutive years, for example. Likewise, for the diagnosis of seasonal affective disorder, if the individual has had multiple episodes of depression at different times in their life, The seasonal episodes must outnumber the non-seasonal episodes to make the diagnosis. So what are exactly the symptoms that we use for diagnosing depression? We base the criteria on the DSM-5, the Diagnostic and Statistical Manual of the American Psychiatric Association. So the first two key symptoms are depressed mood most of the day, nearly every day, and or anhedonia, which means a decrease in interest or pleasure in usual activities. So people have to have at least one of those two for starters. In addition to one of those two symptoms, or both, they need to have a number of symptoms that are listed here for a total of 5. So these are described by the mnemonic SIGI-CAP. So sleep disturbance, either too much sleep or too little sleep, interest decrease, which we talked about up here, guilt, meaning strong feelings of self-criticism, putting oneself down, or having more concrete guilty feelings about things they may have done or not done in the past. And then E for energy decrease, usually fatigue. C for concentration decrease, very common. Appetite disturbances, either, again, a loss of appetite or an increase in appetite. Then psychomotor changes, either feeling slowed down, the sensation that your thoughts are going slower than normal inside your head. We call this psychomotor retardation. Or the opposite, a feeling of fidgetiness, agitation, difficulty sitting still. We call this psychomotor agitation. And finally, suicidal ideation. This can mean either thoughts that life isn't worth living or that you'd be better off dead, sometimes wishing to fall asleep and never wake up, or actually thinking about killing yourself or hurting yourself in some way, and at the extreme making a plan for it or even acting on it. So to meet criteria for major depressive disorder, you have to have had at least 5 of the above symptoms for at least 2 weeks. Now let's talk about what causes depression or seasonal affective disorder. So in this diagram, I'm showing you what happens in the brain. These are brain cells. And this space in between the two brain cells is called the synapse. So this is called the presynaptic cell, and this is called the postsynaptic cell. So the presynaptic cell manufactures different chemicals, in particular serotonin. And the serotonin is released by these vesicles into this intracellular space. And the molecules of serotonin interact with receptors on the target cell or postsynaptic cell. And then this interaction in turn causes other chemical effects that are thought to be involved in mood regulation. So the belief is that a deficiency of serotonin, having too little serotonin, may cause depression. We know, for example, in the winter months, serotonin turnover is decreased, which means that there may be less serotonin available, whereas exposure to light increases serotonin synthesis. So that might explain why with less light there might be less serotonin and hence the risk of depression. And the compound serotonin, which is also called 5-hydroxytryptamine, is diagrammed down here. Another chemical of relevance in mood is called melatonin. Melatonin is actually a hormone that all humans manufacture in the pineal gland of the brain that you see here on the top right of the slide. So melatonin has a very important function in regulating our sleep and our circadian rhythms, our body clocks, as we say. What is thought to happen with regard to the winter and mood is that During the winter, there's obviously fewer hours of daylight, and when we do get exposure to daylight, it's usually less intense. The sun is less strong. Consequently, fewer photons of light will hit the retina, which you see in this diagram here. And with less light, there's a greater increase. During the winter months, melatonin release may be extended, particularly in seasonal depression, whereas in healthy individuals without depression, we call these people healthy controls for purposes of research studies. The melatonin release is not extended. We see this phenomenon as well in mammals, particularly those who carry out hibernation during the winter, for example, bears. So it may be that the fatigue associated with depression may be a type of hibernatory reaction in humans. And here on the bottom right, you see the chemical melatonin, what it looks like. And in this slide, we see the circadian rhythm. So as you see here on the y-axis, you see the levels of plasma melatonin, how much melatonin there is in the blood. And this refers to the body clock in 24-hour time. So as you can see, during the night, melatonin is at its peak and then drops during the day. It's believed that in seasonal depression, there's a shift in the sleep-wake cycle caused by melatonin imbalances. So the curve is shifted forward, and that represents SAD, Seasonal Affective Disorder. And there may be various factors related to melatonin release, including cortisol, a hormone that we release, a steroid hormone, and body temperature changes. It's not clear exactly how this may lead to depression. The other contributor to depression in general, and possibly to seasonal depression, is genetic factors. We know that depression tends to run in families. If you have a parent or a sibling with depression, it increases your chances of developing depression yourself. So there's thought to be an inheritable component. Genes that are involved in synthesizing the serotonin transporter, remember we talked earlier that serotonin was an important mood regulator. Any abnormalities in these genes could be associated with seasonal depression. Another chemical called dopamine, also released by the nerve cells in the brain, anomalies in the receptor gene that captures dopamine molecules, these anomalies may also be associated with seasonal depression, particularly binge eating, which is often seen in this form of depression. And then there's other genes as well that may affect the circadian clock and contribute to depression. This is quite complicated, and even the scientists themselves don't entirely understand the genetic basis of depression. In addition to biological mechanisms of depression, the field of psychology has also developed ways of understanding depression through psychological models, in particular, those that are called cognitive behavioral models, having to do with how we perceive the world around us and how we may behave as a reaction. So, for example, many people have very negative or dysfunctional attitudes toward the world. Historically, this term has been called neuroticism. It's really no longer used much in psychiatry. The typical neurotic character was the ones that Woody Allen portrayed in most of his movies. In addition, there's a behavior called ruminative coping, which involves excessive focusing on the causes and consequences of being depressed in the fall. So, for example, the person feels less motivated, they may go out less, maybe they don't see their friends as much, and then they start getting depressed as a result of that, or getting down on themselves, thinking about it all the time, feeling that they're missing out on something. And then that in turn creates a vicious cycle where this attitude may make the patients more depressed during the winter months as the fall transitions into winter. And then there's what they call the integrated models, which actually tie in all of these different concepts. In particular, there was Jung's dual vulnerability model that suggests there's a physiologic or biological vulnerability to depression. In particular, with people who have seasonal depression, they may be particularly prone to fatigue, hypersomnia, or increased need for sleep, often as much as 10 hours a day or more. Increased appetite, often people with seasonal depression will gain weight during the winter months. And carbohydrate craving in particular. These individuals will often feel the urge to eat a lot of chocolate, potato chips, and other starchy snacks like that. Along with the physiological vulnerability, there's a psychological vulnerability, meaning that we observe cognitive and mood symptoms that may occur as a reaction or response to the physiologic symptoms above. So for example, the individual eats more, he starts to gain weight, he starts getting upset with himself for gaining weight, and then this contributes to more depression. Again, the vicious circle. All right, now in this next phase, we'll talk a little bit about what can we do about seasonal depression. The most popular and the best studied treatment for seasonal affective disorder is light therapy. Basically, this consists of a lamp that's kept in a box that contains, in particular, fluorescent lamps. And it can't be just any lamp. They're typically lamps that have a strength of 10,000 lux, usually full spectrum or cool white fluorescent lights, and they're placed behind a UV shield so that they won't give too much UV radiation to the eyes. The recommendation is that people use the lamp for anywhere between 30 minutes to 2 hours a day for at least 2 to 4 weeks before they'll see improvement. So improvement tends to be gradual. There are some therapy lamps that are weaker than 10,000 lux, often having 2,500 lux or 5,000. These are of lower intensity and may therefore require longer sessions in order to be effective. So rather than 30 minutes, it might be an hour at a time. How well does light therapy work? There have been many studies done over the years. One of the challenges in interpreting those studies is that most of them tend to have small numbers of people, and the criteria for diagnosing the depression may not be as rigorous as we would like. Ideally, a study of depression should have somewhere between 200 and 300 people, usually half of them assigned to receive an active treatment and the other half to a placebo or sham intervention. A study that large is quite expensive, so most of the studies tend to be smaller than that. However, one strategy that we use when there are a lot of small studies is we pool them together and do what we call a meta-analysis, where essentially we artificially create a large group of people from the various studies lumped together. Looking at these approaches, we find that about half or a little bit more of people receiving light therapy will obtain a full remission, meaning they're essentially fully recovered from the depression. In particular, people who have more moderate to severe seasonal affective disorder do quite well. About 43% of people will attain remission, which for people with moderate to severe depression, that's actually quite good. However, studies have also shown that light therapy is not always enough to combat depression. Oftentimes, the light therapy needs to be combined with antidepressant medications so that the two will work synergistically in order to produce the desired effect. Now, what are some of the side effects that may occur with light therapy? The most common ones that I've listed here include headaches, eye strain, sometimes agitation or irritation, and nausea. These have been reported. They're among the most common. There are ways that we can manage them or prevent them. If you do get headaches or eye strain, they recommend maybe reducing the treatment time. Don't start with 1 to 2 hours, but maybe do, 20 minutes twice a day and see how it goes. Sometimes just keeping the light box farther from you may help. In this photograph over here, the woman has it set on her desk, and you'll notice it's at an angle, so the light isn't hitting her eyes directly. And this can help to prevent eye strain or headaches. Taking breaks between sessions is a good idea. So don't do 2 hours straight, but break it up into smaller sessions. Usually putting the lamp somewhere where you tend to spend a lot of time. It can be the desk where you work or next to the chair where you sit to watch television. That way you can turn it on when you're there and it becomes part of your normal routine. It's not like you have to turn it on and just sit there doing nothing until you've gone through the 30 minutes or more. In some cases, changing the time of day during which you use the light therapy can help. So for example, sometimes you might want to do it in the morning, sometimes you might want to do it in the afternoon or evening. You need to experiment a little bit and see what works for you. There are some more serious, what we call contraindications. Relative contraindications means the treatment is not strongly recommended in certain people, but they may still use it depending on the circumstances. So for example, people with disease of the retina, we talked about eye strain, that could mean that light therapy may not be desirable for these people. There are certain medical conditions, for example, lupus, or certain medications that may increase sensitivity to light. So these individuals should not be using the therapy lamp. At least it's not desirable to do so because it may potentially trigger, a kind of a sunburn type of reaction. And then there's people with bipolar disorder, which I mentioned earlier. Light therapy can sometimes trigger attacks of mania or hypomania. This can happen, by the way, with any antidepressant treatment, with medications, for example, antidepressants. Those can trigger mania or hypomania as well. In these cases, it's always best to check with a physician before beginning a course of light therapy. And in particular, individuals with bipolar disorder should probably consult with a psychiatrist who may recommend some strategies for preventing mania. For example, giving the patient a mood stabilizing drug to prevent mania is one potential way to prevent these problems. So again, these contraindications are not absolute, but these individuals that I've mentioned here should use light therapy with caution and preferably under the supervision of a doctor. Light therapy has also been studied to a lesser degree in other conditions. For example, in certain forms of depression or other mood disorders that don't occur seasonally. So people with regular major depression may also benefit from light therapy. It's been shown, for example, that in people with more chronic depression, adding light to the regular antidepressant treatment during the fall and winter months can prevent worsening of depression that may occur during that time. Jet lag. There are a lot of people who purchase very small lamps of this type that can be taken in a suitcase or in a carry-on. And when they travel across time zones, the therapy lamp can help them to attain a more normalized circadian rhythm in their new time zone. It seems to accelerate the adjustment period after traveling. Certain sleep disorders where the individual may not necessarily be depressed or anxious, but has trouble sleeping. These individuals can benefit from light therapy. And there's people who have to work night shifts, for example, nurses who may be rotated into night shifts in an emergency room for part of the year, or physicians as well, or factory workers who may have to work night shifts. These individuals may be able to adjust more easily by using the therapy lamp. Finally, there have been cases of people with dementia, such as Alzheimer's disease. These people may benefit from a little exposure to light. There's a phenomenon called sundowning that occurs as the evening sets in. It's thought that the lack of light means less stimulus for the individual, and so they may become more distressed or more agitated. A little exposure to the therapy lamp may help in that regard. So if you decide you want to try a therapy lamp, what's your best approach? Well, I think talking to the doctor is a good idea, and the doctor can help you come up with a plan to tailor the exposure based on what your particular daily rhythms and lifestyle may be. There's some evidence that using the lamp in the morning may be more effective than using it in the evening. For this reason, perhaps having 2 sessions a day may be the best approach, just to give you the broadest possible coverage. So usually 1 session in the morning, 1 session in the evening. I mentioned the transportable lamps that you can get if you're someone who travels frequently across time zones. That can potentially help you to adjust to your new time zone. So when should people begin using the lamp? It's generally recommended to begin use in the early fall, when the weather starts becoming cloudier, so you get less exposure to the sun. So I usually tell my patients start in September, October, because this can prevent the depression from occurring, or at least making it less severe from the get-go if it does happen. And usually people should continue using the lamp on a daily basis until the spring. At that point, the outer light is greater and can help to sustain the individual's mood and their energy. There are some people who also use it off-season. For example, in the summer, you might get a week when it's very cloudy or rainy. Well, using the lamp during those gray days may also help, especially if you're a person who's acutely sensitive to changes in the weather. Whatever you do, I think the key to this and to any treatment for depression is to find a schedule that suits your situation and stick with it for the long term. And that gives you the best chance of success. What else? I mentioned setting up the lamp in a place where you're likely to spend a fair amount of time, such as your desk or your easy chair. Then turn the light on while you're reading or watching TV or working at your computer. This gives you a way of using it efficiently, because you're using it during times that you're doing things that you normally do. It's not like you need to find an extra hour during the day to do the lamp. And again, let the light hit your eyes indirectly. As you see in the picture here, the woman on the top right, you see the light is going indirectly to the eyes from an angle. Because again, looking at the lamp directly for long periods of time can be harmful to the eyes. Let me say a little bit about some other treatments that are also available besides light therapy. There have been some studies done on ultraviolet light. Basically, again, ultraviolet light radiation can be applied to the skin or the eyes. There's about 7 studies in which 6 of them showed a benefit in mood. But these studies are small and tend to vary a lot in terms of how they were designed, which types of individuals with depression were recruited. So consequently, it's hard to generalize from all of it. I consider these results preliminary, though certainly compelling. I do tell people, don't try to use a tanning bed for mood elevation. That would be way too much exposure to ultraviolet light. And what about medications? Certainly antidepressants can work quite well for seasonal depression, as they do for regular depression. The selective serotonin reuptake inhibitors, or SSRIs, can be combined with light therapy. In particular, fluoxetine, also known as Prozac, and sertraline, also known as Zoloft, are among the ones that have been studied. Another study combined light therapy with citalopram, which is also called Celexa, and over a 34-week period, people benefited. There are other types of antidepressants, for example, the monoamine oxidase inhibitors. There's one in particular, meclobamide, which is reversible. This one too was shown to be effective for seasonal depression. There's a stimulant called modafinil, which is actually a treatment for narcolepsy, that condition where people can suddenly fall asleep out of the blue for no reason, and that's been shown to be effective. And then drugs called beta blockers like propranolol, which lower the blood pressure, they seem to have a melatonin suppressing effect, and therefore may be of some use in treating seasonal depressions. And then going back to what I was saying earlier about the psychological models, cognitive behavioral therapy, or CBT, has been used in seasonal depression. There are specific approaches or protocols that have been designed specifically to manage seasonal depression. These typically include 90-minute sessions twice weekly for about 6 weeks. And the main goal of CBT is to counteract the hibernation behavior in the patients by encouraging more activity during the winter. So get yourself out of bed, get dressed, get outside, go for a walk, do something. Don't just sit around all day doing nothing. The other aspect of CBT for seasonal depression is that it can help to eliminate negative beliefs or cognitions that are related to the winter. There have been some studies comparing CBT and light therapy, as well as the combination of the two. By and large, they all seemed to work equally well. So CBT by itself was as effective as light therapy, and the two together, that didn't seem to have an additive effect. So sometimes that's what happens when you combine multiple treatments for depression. Sometimes you get an additive effect, sometimes you don't. Exercise. Studies have shown that aerobic exercise, in particular, doing a session on the stationary bike twice daily for 25 minutes in the afternoon for a week, actually had benefits after only 1 week of activity, as much as light therapy had for people with seasonal depression. In particular, it's also been shown that aerobic exercise under bright light is better than not exercising or exercising under normal light, particularly for what we call atypical symptoms of depression, which are the ones we see in seasonal depression, the increase in appetite, the increased need for sleep, for example. So the conclusion of this is that outdoor exercise might be the best approach to take in combating seasonal depression. In my experience working with patients over the years, it's very difficult to get a depressed individual to exercise. But sometimes encouraging even some brisk walking can make a difference. So any kind of activity that raises your heartbeat a little bit can be a good idea if you suffer from seasonal depression. So to conclude, depression is common, and seasonal affective disorder is also relatively common, particularly in parts of the world where the winters tend to be long and dark. There are many treatments available, as I've outlined here. Unfortunately, most have not been very well studied or characterized, so we need more research in order to help us to understand better about seasonal depression, what are its biological underpinnings, and what are the best treatments that we can offer to individuals who suffer from this disorder. So if you think you may have seasonal depression or any other type of depression, I would say try to see a psychiatrist or another qualified mental health professional, such as a psychologist or a certified social worker who specializes in psychiatric treatment, or even your primary care doctor. If you're depressed for any reason, don't try to self-diagnose or self-treat without a professional on board to help to advise you and to guide you. If your seasonal depression is particularly severe, you'll probably need more aggressive treatment, typically being a combination of antidepressant medications and light therapy. Another consideration, particularly in this part of the world, is vitamin D. There is increasing evidence that vitamin D deficiencies may be associated with depression, and vitamin D synthesis in humans requires exposure to the sun, unless you're taking supplements that give you extra vitamin D. If you live in Boston or New Hampshire, Vermont, chances are you're not synthesizing enough vitamin D even during the summer months. So supplementing would probably be a good idea. From a behavioral standpoint, there are things you can do. You can push yourself to avoid hibernation behaviors. Stay in bed only to sleep and get out of bed when it's time to get up. Go out, even if you're not too thrilled about doing so. Go easy on the sweets. Try not to overdo the carbohydrates. Try to establish normal sleep patterns. This term is referred to as sleep hygiene, meaning, for example, go to bed at the same time each night and plan to wake up the next morning at the same time every day. Avoid things that may disrupt your sleep late in the evening. So try to stop eating and drinking at least a couple of hours before bedtime. Don't spend too much time on the cell phone before going to bed, because the light can again fool your body into thinking that it's still daytime. And obviously avoid trying to do things that may be potentially stressful, like trying to do your tax returns or anything late at night, because it may keep you from sleeping well. And finally, physical activity. Again, I keep emphasizing this. Get any physical activity you can, particularly outdoors is best. So these are some of the things you can do if you think you have seasonal depression or have been diagnosed with it. Okay, so that's the presentation. So I want to thank you for your attention, and I thought I'd end with a slide showing the sunlight, the light at the end of the tunnel. So I'll be happy to answer any questions at this time.
All right. We did have a question in the chat. It was, when using at night in an AM/PM schedule, should you use a certain number of hours before going to bed to not affect being able to sleep? And then there was also a question of what brand of light would be good, or a style that would be good.
Okay. If you're doing the twice a day regimen, or if you choose to do your light therapy in the evening, yes, it's not a good idea to do it too close to your bedtime. So I would say be finished with your session at least 2 hours before bedtime. Don't do it right before going to bed, because that may make it harder to sleep. Regarding different types of lamps, I don't recommend any particular brand, because by and large they're all pretty much the same. The key is to look at the label to see the strength. So I said 10,000 lux is optimal, but even those that have 5,000 or 2,500 may also be beneficial, but they may require longer sessions. It pays to shop around. There are many different brands available, and you can get a good deal with some careful shopping. You don't necessarily need to spend a huge amount of money. So shop around, read the label carefully, and as long as it's a 10,000 lux lamp, it should work for your purposes. Other questions?
There was a question about light therapy for someone who has glaucoma and or cataracts.
Okay. Um, sure. Glaucoma and cataracts are not a disease of the retina per se. So in theory, the light therapy should probably not be a factor. However, I do advise caution in anybody with eye problems, because if you have glaucoma or cataracts and on top of that potentially strain your retina, then you could have additional problems. So I would say if you have any kind of eye disease, you should talk to your ophthalmologist, your eye doctor, before using any kind of light therapy. I think that would be the most prudent approach to take.
Right. Are there any other questions? Feel free to unmute yourself or to send something into the chat. Okay, well, if that is the case, thank you everyone for coming. I hope that this program was helpful, and thankfully spring might be here before we know it. The ground, I know it doesn't really mean anything, but hopefully that groundhog will not see its shadow.
All right, well, very good. Well, thank you everybody for coming. I hope hope you found the program useful, and I hope you'll have a happy and healthy holiday season and a good new year.
Yep. I mean, 2020 is almost at an end. That's really a light at the end of the tunnel. All right, well, thank you for coming, everyone, and good night.
Good night.
Thank you. Bye.
Bye. All right.